Hi, everybody. Thank you so much for joining us today. My name is Nicole Lamberson. I am a physician assistant. I also do outreach for the film Medicating Normal. I'm so excited to bring you our second live interview with one of the wonderful individuals we met along the journey of making and screening the film. Our guest today is Dr. Michael Bohan. Is it Bohan or Bohan? Sorry.
Bohan.
Bohan. We first met Dr. Bohan at an in-person screening of Medicating Normal in Virginia last October. Both Dr. Bohan and I are in Virginia. A little bit about him. He is board certified in addiction medicine and internal medicine. He's retired from the U.S. Navy Medical Corps. While in the Navy, he developed an interest in addiction medicine, first alcoholism treatment 1968, and later benzodiazepine use disorders in 1978. He started to work full-time in addiction medicine in 1982 after he retired from the Navy. The World Service Office of Narcotics Anonymous asked him to serve on their board of trustees as a non-addict in 1981. His term ended in 1987. Meridian Psychotherapy in Virginia Beach has been his professional home since 1992. In 1991, he started working treatment of sexual compulsive disorders as well and served on the board of the Society for the Advancement of Sexual Health from 1998 until 2004. He has been an associate professor of internal medicine at the Eastern Virginia School of Medicine since 1978. He also joined as a medical board member of the Benzodiazepine Information Coalition. Treatment of benzodiazepine use disorders using agonist therapy with diazepam has been a large interest of Dr. Bohan and other prescribers at Meridian Psychotherapy. On October 26, 2019, he presented a workshop on benzodiazepine withdrawal to the Virginia Society of Addiction Medicine. He names his greatest teachers in the treatment of benzodiazepine use disorders as his patients. Dr. Bohan, thank you so much for joining us.
Thank you.
So I think we'll start out today just asking you a few questions to get the conversation going, and then we'll start taking questions from the audience. So first, your bio says you developed an interest in benzodiazepines in 1978. That's a long time ago. I was born in 1978. What sparked your interest in the drug class and specifically the problems that the class carries?
Well, I guess I'll start off a little bit by saying how I got involved in addiction at all. I was in the Navy and took my residency at the Portsmouth Naval Hospital, Philadelphia Naval Hospital. And one day, working on a unit which was totally devoted to alcoholism, also the consequences of alcohol, we weren't doing anything about helping people get better, like going to AA and such. A patient who had been a repeater, I guess, came in and out all the time, walked in to tell me that he was then in AA, and that helped him a lot. And he said, maybe that'll help others. I didn't pay much attention to that then, but later when my next duty was in Sasebo, Japan, and a patient was involved in detox repeatedly. Every month he'd come in for detox. He said, doctor, there must be a better way. And I said, my uncle got better in AA, let's write to AA. So we wrote to AA. We got material to start an AA meeting. And he said, okay, doc, you can help us start the AA meeting. I said, well, I'm not alcoholic. I can't go to those meetings. He said, well, here we have open meetings and closed meetings. Open meetings, anybody can go. I said, okay. So I started going. And of course, it really changed my life. It changed to see how I could see how people could get better. And also introducing the spiritual connection, as far as recovery goes. Then I went to Naval Hospital in Boston. We started alcoholism programs there. Then the Bethesda Naval Hospital continued. Then my last duty was in Portsmouth Naval Hospital as chief of medicine there. And as chief of medicine, I was in charge of the medicine clinics and medicine wards and such. And some of the patients, I guess, who were going to the clinics and had been prescribed benzodiazepines, oftentimes gotten a bit of a tiff with their doctor because maybe the doctor wasn't giving them what they wanted. So they came to my office to complain. So realized not really, I guess they sort of walked into a trap, but I hope it's a blessed one, because I get to see many patients who are benzo dependent. So we started forming groups. and started working on detox. And I found then that the long-acting benzos, that is the Librium and diazepam, seemed to help them better than using the short-acting ones. Interestingly, one of the patients had a friend who was a newspaper reporter, and he mentioned his recovery, his getting better, to the newspaper reporter. The reporter worked for the local paper, the Virginian Pilot, and he did an article on the patient and mentioned my name. Well, so happened that the drug detailer, that is the salesperson for the drug company, for one of the benzodiazepines, he read it and he sent the information to the medical director of his company. And the medical director called me on the phone. And I said, who do you think you are, saying these people are addicted to benzos? So I said, well, that's the way it goes. I said, why don't you come on down and introduce you to some? So we got a group together, 4 patients who were, in the detox and some had recovered, to meet with him. But he discounted them all. He saw reasons why he couldn't believe them. So from then, I guess I just continued to be more and more involved. And then I got out of the Navy and then started working in, outpatient and inpatient detox. So then I got more and more involved. And then, of course, I really didn't get fine-tuned, I guess, till Heather Ashton's manual came available in the early 90s. And then we started following her protocols. But I'm I see so many people getting better. It's so wonderful to see. Of course, one of the issues, too, is the fact that I had the problem was going on in my family even before then. My dad was a doctor, and he became dependent upon the benzodiazepines. And his life was totally out of control when he did. He also sometimes combined it with alcohol, which made it even worse, He died in 1989. I think a lot of it had to do with withdrawal, from the benzos. And other sad experience was the fact that he prescribed benzos to my Uncle Johnny. And Johnny died of suicide. Unfortunately, he was profoundly addicted to these drugs. I remember after he died talking to his wife, and he worked as a toll collector at the Delaware Memorial Bridge outside of Wilmington. And when he went to work, he had one benzodiazepine pill in one shirt pocket, one in another shirt pocket, one in each pockets of his pants. So he went off with 4 benzos to work every day. So, that was it. And not only that, I guess his sister, my aunt Kathleen, she became dependent upon benzos too. She was on Xanax and she fell and cut herself a large gash in her side. She was in the hospital for months. And I went to visit her and I saw that looked to me like she was having some benzo withdrawal symptoms. I talked to her doctor and he tapered her off Xanax. And so I appreciate my appreciation to him that then as she got better, I went to visit her again and she's back on Xanax. So I went to the doctor again. He says, I said, well, how come she's back on Xanax? Oh, she wanted them. So, kind of tragic again. So now all that what was going on in my family wasn't the main propeller of my interest, but I'm sure it fed into it. It feeds into it today because I can reflect on my family members and see how they were tortured actually by these drugs, and that helps me to sustains me, I guess, in helping others with the same problem.
Yeah. So there was actually a physician in your family who prescribed them for another family member.
Right. Mm-hmm.
Was this like, back in the times where, pre-Ashton, where everyone was on benzos and nobody really knew much about it? It
was pre-Ashton. My father died in 89 and the Ashton manual came out in 91. Wow. And my Uncle Johnny died in 1986. So so there were, and Goog was, she was a little bit later than that. Mm-hmm. She died probably in 1991. So,
wow. Well, that's very interesting that it's even affected your own family, and you.
Yeah. And just to pick up on that a little bit, because of that, you mentioned that I was on the board of trustees of NA. The first NA trustee meeting I went to was in Miami at the NA convention. NA was pretty small at the time. This was 1981. And at that meeting, they had a Naranon meeting, Naranon, for the families of addicts. It's like Al-Anon is to AA, and Naranon is to NA. So I went to that meeting and said, oh, that's where I belong. So I've been going ever since, to those meetings to work on detachment, from the seeing this as a disease, recognizing that these people didn't have a choice. Their choice was taken from them. And getting rid of blame and all. Just working on that. And of course, it helps me too in dealing with addicts in my life. Now, with the benzodiazepine patients, not everyone has the addiction problem in the sense that they're out stealing or dealing or the drugs. Most patients are people, I say, who follow the rules. They're getting the medication, they're following the doctor's orders, and they maybe have to keep increasing a dose because of withdrawal symptoms starting to appear, and then because they don't know their withdrawal symptoms, but
Right.
they gradually go up and up on the dose. But then there's another group of patients who are often street use, and now we have designer use of the benzos, which are really, it's a very powerful. I had an adolescent patient last year, or maybe year before last, who became addicted to a drug called clonazepam. It's only you have to, but you can get it online. But it caused him to be really, really insane, I'd say. So yeah. So anyway, so these anyway. So there are two groups of patients. One follow the rules. One patients can't follow the rules, and their tolerance level is usually higher. They hoard drugs. Oftentimes, they'll have a stash of large amounts of benzos. They'll get them from different sources or buy them on the street and stuff like that.
And I noticed, like, when you were describing things, you use addiction terminology sometimes, and then other times you say dependence. When you say dependence, are you describing like the physiological dependence, separating that from addiction, like in the two scenarios you just gave, the rule followers and then people who are actually misusing or abusing benzodiazepines?
We have the DSM-5 criteria for substance use disorder, for sedative substance use disorder in case of benzodiazepines, and the patients who follow the rules usually it's mild, moderate, and severe. They would be mild, and they usually don't have the cravings or don't have as much, or they don't have the issues that addiction problems they can't set boundaries. They set boundaries with the drugs, the others can't. Okay. So then the addicts, then people who have addiction problem, of course, we're trying to stop. I guess I just took a training just the other day. We talked about switching the terminology from addict to substance use disorder.
Okay.
But when I do say addict, I'm saying that here because then that tells you the difference between the two groups of patients. The ones who follow the rules, they're much more easier to treat. The others are very difficult to treat. They have to get involved in addiction treatment, NA, and such as well.
Okay. Got you. So when we first met you, you were at the in-person screening of Medicating Normal in Virginia, and you came up and you stood up in front of the audience and you told of some of the cases of the patients that you've treated in benzodiazepine withdrawal. What kinds of things have you seen in the way of symptoms or presentations? Like when you and I actually were talking before we went live, you told me you can smell benzodiazepine withdrawal. So what is it that tips you off?
I'll give you an example. Then working in the psychiatric center on the detox unit, I walk on the unit and I hear this wailing going on, somebody wailing. And this is a patient who's crying and wailing and just unable to be consoled. And it's overwhelming. The nurses don't want to go in her room. There's nothing anybody can do to help her. One of the patients I heard was like this. I was walking on the unit and I heard her doctor happened to be at the nurse's station. And I said to him, I'll take that patient. You will? I said, sure. So because I knew what it was, because I've heard it over and over, that wailing, and that's the benzo patient who's been off benzos for a while, usually high dose benzo patient, and just this unconsolable grief and crying that they have. So once we got her started on the benzos, she was fine. I mean, once we started following the Ashton model, matched her tolerance with diazepam, and then discharged her to follow as an outpatient. And it took her almost 2 years, but she got off and she's fine. So that would be one thing. Another I'll mention is pain, and this is I missed the boat on this for many years. And this was the patient who had abdominal pain or pain in the side, or even sometimes back pain. And these are patient been on benzos and they're off or down to very low dose, whatever. And that pain is due to withdrawal. And they have all the upper GIs, CAT scans, they all show nothing. But once we get them started on the benzo, if they're on benzos, and the benzos, their pain will go away. Another case is isolation. I had a patient who called me once and he heard that I was doing benzo withdrawal. He says, I'd like to come and see you, but I can't leave my house. This was before the coronavirus, So I said, well, I'll come see you. So we live in Norfolk. And so I went to his home and all the shades were drawn except one. On one window, the shade is up just a couple inches and I could see 2 eyes peering out. So I knocked on the door and that was the man. He says, oh, glad you came to see me. So isolation is uniform, especially in high dose. People aren't able to well, of course, Nicole, you know how limited interest or knowledge there is about this whole issue even in medical community. Yeah. But anyway, there are a couple of instances of how we spot it, I guess, and try to help.
Yeah. Well, for people who are watching who don't know, I actually took benzodiazepines myself. I have been off of them for many, many years, but I'm smiling and nodding my head because I had all of those things that you're describing as well. The pain, the agoraphobia, such weird behaviors. Somebody would ring the doorbell and I would run upstairs and hide, things like that. So yeah, it's interesting that you mention.
Yeah, and as you talk about it, that's nothing you can get over.
Mm-hmm.
You just can't. It's not a case of mind over matter. That doesn't work.
Right.
And you have to have someone who understands this problem to help, because otherwise, oftentimes people like you would end up in psychiatric hospitals, and people would be trying to treat you for all sorts of psychological conditions, which you really never had.
Yeah, and well, that's where the polypharmacy comes into play, yeah. Right? Because they just start adding more drugs, attempting to treat what is really benzodiazepine tolerance and interdose and that kind of thing, right? Yeah.
Yeah.
Okay, let's see. So with the COVID that we're all facing right now, and the heightened anxiety that everyone is having, if people are considering taking a benzodiazepine for that type of anxiety, what type of informed consent would you want to give to a patient like that? Well,
in the first place, you can guess that I would never recommend any medication to treat, which see, something like you're talking about, that's a stressor. Mm-hmm. That the COVID and we are facing stressors now with confinement and stuff like that, but it certainly shouldn't be medicated because medicating is only going to make it worse. Mm-hmm. One thing about, say, with the benzodiazepines, there's tolerance involved, and it's unavoidable. It's not a matter of choice. As you go on, the dose has to usually gradually goes up, and so this is called chronic tolerance. And it's unavoidable. As I said, it's unavoidable. With the benzos, there's a thing called maximal tolerance. You get to a certain level, then you don't, and you don't go any higher. Now, there's no maximal limit for opiates, but there is for benzos and alcohol. The maximal tolerance probably, I would say, about 8 milligrams of Xanax or 10 milligrams of Xanax a day. You don't see much higher than that. Sometimes the illegal users are taking more, but most illegal users, because the pharmacies too won't give anymore. But anyway, that's how the tolerance builds. One thing that you mentioned, this situation with the COVID. What about grief? That's something we see a lot. I remember oneself when I like to swim, and it's at Hawaii and a place in California. I was swimming, and I got out of the pool, was getting dressed, and two men standing next to me. One was talking to the other. One man was talking about a close family friend who died, and then the man next to him was a doctor. And right away he says, "Well, you need something for that." And he reaches in his pocket, writes out a prescription for Xanax. This is out of the clear blue. This is a doctor treating grief with Xanax. One thing you can be sure of: if you treat grief with Xanax, you're not going to get over the grief, because the grief response is suspended. If you keep it, it doesn't go away, unfortunately. So yeah.
Yeah, we just had a talk on grief last week with a grief therapist, and part of the discussion was about you medicate it and you're just kicking the can, down the road, because
Right.
once you get off the medications, it's much, much worse.
Mm-hmm.
So have you seen the latest FDA labeling changes that were announced last week for the benzodiazepines? I know a lot of people who were campaigning, tirelessly. Some people in the communities for decades were campaigning for changes around benzodiazepines.
Mm-hmm.
So I think it's better late than never, of course, but what do you think about the new FDA advance?
Well, I read the press release. Every little bit helps, of course. Gaining the FDA's interest is very helpful, but it won't be enough. Let me ask you, Nicole.
Mm-hmm.
You're a nurse practitioner. Do you think the doctors are going to be reading the product, the box on these benzos? I mean, do you think that was?
Well, probably not.
Right.
Yeah.
So I think it's fine, but it's not really getting at the heart of the problem. That is what I think. The heart of the problem is, how can we communicate this to more doctors and nurse practitioners, other prescribers, whereby everybody jumps on board. Now, everybody seems to be jumping on board in Virginia anyway on the opiates, and doctors are scared of writing them. We need the same sort of effort on benzos.
Right. Well, and also comes, the trouble with benzodiazepines. They are so complex, I guess, in the way that, you have to manage them, the withdrawal over such a long period of time. Well, first you have to recognize and know what you're even treating.
Yeah.
And so when something like this happens, like a black box warning, or, like with the opioids, how you were saying, no, everyone's afraid to write them now. I think one of the big concerns is that that's going to happen with benzodiazepines. And then patients who are already physically dependent are going to go back to their doctor wanting to taper over a couple of years' time or something. And they're just going to be told, no, they're going to be cut off and sent home in horrible withdrawal.
Let me ask you too, Nicole, about the informed consent that's coming up in Massachusetts.
Mm-hmm.
That would go a long way if it was throughout the United States to point out the problems that are associated with benzos and make doctors aware, and have the patients, they'd have to sign informed consent before they get the medication.
Yeah. That bill. Well, there's a bunch of bills actually similar that have kind of spawned off in other states too, that it's really a grassroots thing. The sufferers of benzodiazepines sort of set this all in motion. But as when something goes into like legislation, it's many, many years before anything can come to be. Mm-hmm. And there were actually physicians who showed up in Massachusetts to contest. They did not want informed consent for benzodiazepines. So
that's being anti-scientific. We have to be scientific. We know I went in many years ago, went to meet with Dr. Kalanda, University of Toronto, who was expert he's a pharmacologist, expert on tolerance and dependence to benzodiazepines and other depressant drugs. And he told us about all this is pretty well. I wish everyone could learn and know about the tolerance and dependence. It's actually pretty simple. Tolerance begins with all habit-forming drugs. I mentioned about maximal tolerance. Another aspect of tolerance is called cross-tolerance, where if you become dependent upon benzos, you're automatically dependent upon alcohol. You know, and in fact, I see people who hey, can't get access to the benzos will drink. Oh, maybe never drank before, but they'll be drinking because that will cover their withdrawal symptoms.
Yeah.
Another aspect of tolerance is called remembering, where if you stop taking benzos, say now, if you're going to go back, you say you're taking 2 or 3 milligrams of Xanax a day, if you were to start it a couple of years from now, you wouldn't get much effect from a smaller dose than that because your brain remembers your last dose. And that's sort of, that's put it on the brain. And the other is withdrawal symptoms or depressant. This is called dependency. And this is where you get the symptoms you designed. Okay, I'll say this. All addicting drugs cause the symptoms are designed to relieve. Now you take Xanax to get rid of anxiety, what do you get?
Really
more
bad
anxiety. Right?
Yeah.
So build into the drug, build into Xanax is more anxiety.
Yes.
Now that's a pretty simple statement, but it's powerful because it covers a lot of territory. And it's a paradox. The paradox is hard. The reason why it's hard to understand, you know, the paradox is the truth contained in the opposite. So you take Xanax, get rid of anxiety, you get anxiety. You know, so that's the same with other drugs. Stimulants will make you sleepy, and painkillers will cause pain. Cause withdrawal symptoms. But and one last thing about this tolerance, dependence, and sensitization is one more thing called sensitization. And this is where this is in AA, they call it people, places, and things. This is where the drugs gain undue power. And I'll give you a little example of sensitization when it comes to benzos. When somebody starts saying, my Xanax, when they not the Xanax, but my Xanax, but when they get to that point, then Xanax is one. And it's got that, develop a close relationship with the patient.
Yeah. Well, some of that too might be because, you know, I hear the same thing like my anxiety disorder or my, you know, you sort of, the patient begins to identify with the label that they're given as well.
Yeah.
You know.
Well, can I add on to that a little bit about anxiety disorder? Don't you think, I think for the most part, anxiety is a symptom.
Yeah. Or it's, you know, it's just, I mean, I've spoken to other physicians who are aware of the benzodiazepine problem and stuff, and they say, you know, introduce me to one human being that doesn't have anxiety. I mean, it's a normal, natural part of us being humans. And in fact, you could make the argument that it allowed us to evolve and kept us alive. I mean, anxiety serves a purpose.
Yeah, I like the way you said it. It's a stressor, and we learn from the stressors. Yeah. Now, sometimes people have panic attacks or they have PTSD and things like that. And that time, then those things might need medication. But there's other medications which are not addicting, which probably work as well or even better for panic attacks. Because like I say, you take the drugs, you can't grieve. Also, you're not. How are you going to be able to deal with anxiety if you're taking a drug like Xanax, which will prevent you from really learning how to deal with anxiety?
Well, and you know what? I sort of came to the revelation after going through all this benzodiazepine stuff myself is that if I would have used the coping mechanisms that I eventually was forced to use when I was trying to come off of benzodiazepines, because the withdrawal anxiety and panic and everything else was 100 times worse than the dinky little anxiety that I had it to begin with. So you're going to be using these coping mechanisms at some time in the timeline. You may as well use them on the lesser, you know, anxiety that you have in the beginning instead of what benzos can create for you, which is this horrible nightmare.
Yeah, that's really well spoken, because new stressors arrive while you're taking the benzos, and you won't be able to deal with them.
Yeah. So I have one more question for you, and then we can turn to some of the audience questions. In your bio, you said that in the treatment of benzodiazepine dependence, your greatest teachers are your patients. What have they taught you?
Well, okay. When it comes to the benzos, one of the things that I've been learning about is about the tapering. Now, we follow the Ashton manual pretty closely, except for a couple things. One, Dr. Ashton has the patients blending the drugs they were taking, like Klonopin and with Valium, you blend it for maybe up to a month or so,
You mean
gradually decreasing
in
the
the crossover period?
yeah, gradually over. But I don't do that. I start off with diazepam alone. And it takes about 5 days for that to build up in their system. So they may need a lot of support, I guess, those first 5 days. But after that, then it sort of kicks in. So it eliminates the need for this. It's confusing too, and confusing oftentimes for pharmacists to give them 2 benzos, you know. So that's one thing that I have found to be good. Another thing that I've learned is about the taper when it gets to small doses. Although Dr. Ashton's manual usually ends at 1 milligram, 1 milligram is a lot. And oftentimes patients have a tough time getting from 1 to 0. And in that time, sometimes they're going down by tenths of milligrams. And to do that, we use the jeweler's scale, which I learned from a patient, which is a scale you can buy at Amazon for $25, you know, and then they weigh the pills, and one of our patients set up an Excel spreadsheet to help to map out the gradual taper from 1 milligram to none over a period of months. You know, that would be another patient developed a using milk, aliquots of milk, because the benzos dissolve well in fatty fluids, and that being a fatty fluid, you know, milk. And so that was a useful technique. And then of course, others will use the liquid. The liquid's been manufactured in 1 milligram per ml, 1 milligram per cc. And sometimes we use that. And I learned this. Okay, this is something I learned just pretty good lesson. Like a lesson I learned recently. One of my patients is in a nursing home, and so we're going down. And she's down at right now at 3, 4. She's at 3 milligrams right now. But when we're down about 5 milligrams, that would mean taking 2 milligrams and a half of a 2 milligram. That would be 1, so a total of 5. So now you have to cut the pill in half. Now the nursing home won't cut the pill.
Oh.
The family doesn't want to cut the pill. So I went to the pharmacy to pick up our prescription. And at the pharmacy, I got a pill cutter and cut the pills. But what I found is there's a lot of wastage, and it's not very accurate, you know. So now for her, what I did, I switched over to the liquid. So then what we did, we gave her the 2 tablets and then 1 ml on the liquid. And now she's down to 3 milligrams. I switched to the liquid altogether, you know, because it goes on. The one thing you have to do is to put it way in the back of the throat, because it's just staying in the mouth. It gets absorbed through your buccal mucosa from the mouth. So anyway, but there's a lesson I learned from the patient. So I learned, and there's many more, but anyway, there's some of the ones I learned from them.
Wow. Yeah. Well, that's great that you're willing to try all the techniques and stuff too, because sometimes, you know, we hear from the patients in the community that they take these methods to the physician, and the physician is just resistant to altering the drug in any way. But you know, as you just explained, sometimes the only way for people to find a way off is to be creative and to try these other, using a scale or, you know, mixing the medication with milk. So
yeah, well, the scale now, going back to the scale for a second, the patient had recently, he got a gelatin capsule, you know, these capsules, empty capsules from the pharmacy, and put the powder in the capsule. And that's probably better than put it in your mouth, because it goes into the stomach and absorbs the stomach. We really want to, we're used to we take the drug mainly through the stomach rather than the mouth. I know from some of the patients who violate the rules, they're chewing diazepam or chewing the drugs because they get more of a high from it, because it's absorbed into the mouth and doesn't go through the liver for metabolism, you know, because it goes directly from the mouth to the brain.
Okay. So we have a lot of questions
Okay.
from the audience. I'm going to start with one that I think probably anybody who is either on benzodiazepines or coming off wants to know. Are we really going to get better?
Oh, yes. I mean, we see, you know what, once we get off the patients get over the detox, I don't hear from them. You know, I hear from them when they're on the detox, but not often. But I give all my patients my number. so they can call me, and I rarely get a call. but after they're off, I don't hear from them. They're doing well. I give you a good lesson. The lady who was wailing in the hospital, we graduated over a long period of time, got about 2 years ago off, and so one day one of the office secretaries said to me, she says, "Oh, I saw the patient in the grocery store the other day." I said, "Grocery store? She couldn't leave her house." So yeah, our patients can't fly. They can't do things, but they can once they get drug free.
Yeah.
Yeah.
What about, do you have any patients that didn't taper slowly, that were, they stuck out the cold turkey, and did you see them get better too?
Well, they don't tend to come back. I mean, if they go cold turkey and stop, then they're not really interested in following through to the bitter end. It's not a bitter end, really. It's just they go through the taper process, going down the small doses. Yeah. What I tell patients is, okay, here's the deal. I'm the coach, they're the player. I give them the pills. We talk about the rules and talk about following the rules, and about the process. So as Dr. Ashton says it over and over again, the patient's in charge. so I'm the guide.
Right.
Yeah.
So somebody wants to know, are there any therapies like medications, supplements, psychotherapy treatments, anything that helps while you're going through benzodiazepines?
That's a great idea. One of the things we want to do, we want to get the most we can out of the benzodiazepines. That's the main problem. So we want to get the patients as comfortable. I want the patients to be what I call. It's called the seamless transfer. Mm-hmm. It's going from where you are to none and not know it. Right. That's ideal. We're trying to get as much as we can with the benzos. Now, supplemental. Dr. Ashton mentioned several things, the tricyclic antidepressants, the use of trazodone for sleep and things like that, gabapentin. We try to avoid all those if we can. Gabapentin has its own set of problems. The last patient with gabapentin, we had to detox them off gabapentin while he was on the benzo detox. So that's not very good. There are she mentions propranolol, sometimes for anxiety. That may be helpful. Vistaril. All the drugs are not addicting, or quetiapine or Seroquel. Sometimes that may be helpful. But I think if we need those drugs to get rid of the symptoms, then we maybe aren't doing the job we really need to do with the benzos, Sometimes we have to plateau. Patient recently had one of these patients had terrible back pain because she reduced a little bit too quickly. Now she's on a plateau right now, like for a month, and then when a month's over, then we'll go back to starting reducing again.
Okay. So what you're saying is basically you can control symptoms with the proper taper, and that's possible. The ideal. Yeah. And so if somebody's having a lot of symptoms, you need to examine the rate and speed of the reductions instead of
maybe we're going too fast. You're not going to, if you think that you're going to get help with these other medications, the gabapentin, Seroquel, and things like that, it's not going to work, because when you get down low doses, people will be still having symptoms.
And in your experience, I mean, I know anecdotally, just interacting with the benzodiazepine community a lot, and, from my own experience as well, a lot of people in benzodiazepine withdrawal, and Ashton talks about in her manual too, seem to develop sensitivities where they try other medications or even foods or maybe even things they've tolerated before, and they have adverse reactions to taking new medications and things. Have you seen that in your clinical experience at all?
Oh, occasionally we see that, where people, as you said, that they become ultra sensitive to medications they once tolerated. Not that often, but sometimes but again, we try to avoid those other medications if possible. Now, if you've got about depression and you might need a serious depression, then maybe you need to take antidepressants, things like that. So we're not against people. Believe me, we'll try to get help wherever we can get it. and so some of these things are helpful. We try to do it. Okay, one of the things we have to be guard against when people are having problems. So what I want to do, I check on the prescription monitoring report to see if they're getting drugs from other sources. I redo drug screens to see if they're taking drugs they shouldn't be taking. For example, we want all of our patients to get off caffeine if we can. The caffeine is working against what we're trying to do.
Yes, it's
So
stimulating.
it can cause agitation. And alcohol. It's not, our detox is not going to work if you're drinking on top of it. Yeah.
Okay, so somebody says, how can I stop the irresponsible overprescription of a doctor who is giving their spouse 8 milligrams of Xanax and antidepressants? What can this person do?
Well, it goes through my mind is, I don't know whether I guess here it is. You know, the product literature for Xanax suggests you take the medication for 2 weeks. Mm-hmm. Now, if you're going more than the 2 weeks, I think a case like that could be reported to the Health Regulatory Board. They could call the Health Regulatory Board in their state and report the doctor. Mm-hmm. Now, the problem this person might get into is because maybe his marriage is at stake here. So if he's, it might be best, I guess, if he has his wife's permission to do that. But yeah, that's a tough one. And I guess he can go visit the doctor, like I visited the doctor with regarding my aunt, you know. But you guess you need his wife's permission to do that.
Right. Okay. Somebody wants to know what causes the burning skin and inner vibrating. All this, you know, strange sensations and stuff that we experience when we're in withdrawal.
If you want to look at it scientifically, it's probably caused by the decrease in GABA. Mm-hmm. GABA aminobutyric acid is inhibited by benzos. And if you stop the benzos or cut back on the benzos, the body the GABA is not needed, so it doesn't make it. So there's a decrease in the number of GABA receptors. So that causes agitation. So this is actually a guess on my part. We don't have this, hasn't been proven scientifically what causes all the hypersensitivity. But I think that those hypersensitivity symptoms are probably related to that. And of course, again, if the problem is due to withdrawal, we want to try to help the patient so they get rid of those symptoms. We don't want those symptoms. And if you get the proper dose, I hope you can be able to control those symptoms. Right. Everybody has their own set of symptoms. Not everyone's the same. So that's what we try to do is help them.
Okay. Let's see. So this person says, I've been off and on Klonopin for 30 years. I cold turkeyed with no problems many times. Why am I now having an extremely difficult time getting off? I did switch to diazepam hoping it would make it easier, but diazepam provides no anxiety relief, and I have this constant chemical anxiety.
Well, it's the person may need psychiatric consultation as well, you know, for that anxiety. And we would, of course, is the dose of diazepam meeting her tolerance level of Klonopin? Right.
Yeah. Does it always work? Because they're different drugs, right? They're not identical and they may hit different receptors. Are there any patients where maybe diazepam doesn't fully cover a Klonopin or another?
I don't know. I mean, that could happen, but those drugs are pretty similar as far as the brain has a hard time telling the difference between them. You know, they all fit in the same receptors in the brain. So I'd want to make sure first that we're matching the patient's tolerance. That's number one. And then number two, if we can't get a hold of the symptoms with the diazepam, then we have to look for the psychological help or some other kind of help to see what we can do to help those other symptoms. And then again, the adjunctive medications, they're all listed in the Ashton manual too.
What about patients who are on a benzodiazepine and they're comfortable, say they're on Klonopin and they're comfortable and they're, worried about switching to diazepam, they don't want to make the cross and they want to taper directly from the benzo they're on. Have you ever walked somebody through that?
Yes, that comes a lot. And a lot of the doctors think that using Klonopin is okay to use for taper because it's a longer half-life than Xanax or Ativan. But it's not that long. And we've seen so many patients coming who with Klonopin withdrawal symptoms, that is not a good drug to use. Now, the other thing with Klonopin, why it's not good to use, is because the smallest dose they make is 0.5 milligrams. 0.5 milligrams equals 10 milligrams of Valium.
Right.
I mean, and you even cut that one in half, you're down to 5 milligrams. And you know how much trouble we have coming down even from 1 to 0. Mm-hmm. So Klonopin is not a good drug to use for taper. Diazepam would be the drug to use. Librium probably could be used. We don't. Phenobarbital is another drug can cover the withdrawal symptoms, but the problem there is the smallest dose is 16.2 milligrams, which is equal to 5 milligrams of Valium. Right. So best off to do with what we got, which is the 2 milligram Valium, and then switch to the liquid.
Okay. Let's see. Somebody says, what is a better way to treat anxiety than a benzo?
I think counseling, mindfulness training, meditation.
Right. We were talking about that before we even got on.
Right. Yeah.
I asked him if he was nervous about coming on this interview, and he said a little bit. And then what did you tell me?
Well, I tend to use I go to 12-step meetings for family. I told you about my family history of addiction. So I go to Naranon meetings where we talk about meditation, and so we try to, we work on detachment and carry the higher power with me.
Yeah.
So, I mean, believe me, I'm not perfect about it. This is not like I do get anxious when things like this come up, but still, I'd say I'm a little better than I used to be.
Yeah, same. I think some of it for me was just I had to have tons of practice being in benzo withdrawal, battling such horrible anxiety. But I also learned things that, meditation, like you said, yoga, things that really do work and help, that I wish I would have tried in the beginning because I wouldn't have wound up in this place.
Yeah, we didn't talk about sleep, but that's, a lot of benzo is used for sleep, and people have a lot of sleep problems. That's and even if you're not taking it for sleep, you'll still have sleep problems when you come down on the dose. Mm-hmm. So one thing I often suggest is a course. It's from the Cleveland Clinic. You can take online. It's called CBTI, Cognitive Behavioral Therapy, Eye Insomnia. And it's a free course. It's available to anyone, to take help. And oftentimes we suggest that to our patients, to help with the sleep problems.
During withdrawal, you mean, or before?
Yes. Oh, yeah. Sure. During the withdrawal.
Okay. Okay. When people are being prescribed benzodiazepines, they have symptoms where informed consent is difficult to understand. That is, it's hard to anticipate long-term consequences when they're in pain and anxiety. Do you find that to be true, or?
Well, I'm not sure exactly what they mean. All I guess so as far I haven't seen any of the paperwork for informed consent. I'm not sure how it's worded.
I guess they're saying like when somebody is suffering, it's, they just want relief. So it's very hard for them to understand that there's long-term consequences, or like how would the doctor?
I see. It's hard. Then you have to take it on faith. Mm-hmm. That not like, they need to see the movie, Nicole.
Oh yeah, exactly. They need to watch one of the screenings of Medicating Normal.
Right.
That tells you what happens, right? Yeah. Long term. Well,
Mm-hmm.
that is a good point because, people call for informed consent, like you were talking about them in Massachusetts, and all of the patients who I've met said, well, I didn't get informed consent. Mm-hmm. And myself being a patient, I don't feel like I really got informed consent, which is somebody sitting down with you and telling you what the consequences of this could be long term if you take them, as they were prescribed to you. But I mean, do you really feel like you could get into true informed consent where you could actually describe well enough the nightmare that could result. Because some people say like, oh, you could be dizzy or you could have
Yeah.
anxiety, but does that really impress upon the patient the reality of benzo?
I think the most significant problem with benzo withdrawal is the duration of time, how long it takes.
Yeah.
You can get off alcohol, opiates in a few weeks. You know, they have sometimes post-acute withdrawal syndrome, but nothing compared to this. I don't think anything equals the duration and the intensity, the long intensity of benzo withdrawal. It's terrible. You know, people become, you know, they lose their jobs, they become we talked about all that before, but.
Right. Yes, exactly. So all of those things are informed consent too. You could lose your job, become isolated, all of these things that patients need to know,
Yeah.
you know, before they make the decision to ever take anything like this. What about people who are tapering extremely slowly, but they're still having unbearable symptoms?
Well, then that be best to assess to see if that's maybe even still too fast. What does slow mean? I mean, what difference does it make how long it takes as long as the patient is comfortable? That's my suggestion to patients. You know, now we're not trying to keep people forever. I mean, as patients, we just want we do want them to move along, but we want them to be comfortable as they do it. If they're not comfortable doing it, they maybe have to go back up a little bit.
Right. So we have about 7 minutes left. If there's anything you want to talk about, I do have one more question for you before though. We encounter so much pushback, I guess, from the medical profession, you know, patients do, and even just trying to educate. Is there anything you want to tell to, you know, other physicians or PAs or nurse practitioners or nurses, anybody tuning in who's in the medical field about benzos and, you know, just your thoughts on that for the medical profession?
Well, we don't uniformly have education on benzo withdrawal in the medical curriculum.
Mm-hmm.
You know, now I'm on the faculty of medical school, but I haven't really spent a lot of time with the medical school. But most of my work has been mainly to see our patients at marine psychotherapy, and try to help one patient after another. In fact, I don't even advertise because I'm afraid to, because we have to be able. I shouldn't even be on this program.
Now you're going to have people beating your door down.
Yeah, right. But yeah, so
that tells you something.
What's that?
I said it's because you're invaluable. That tells you something. We need to clone you 1,000,000 times because patients aren't finding doctors who understand. They just, you know, they can't.
I think in working with you, we would like to try to establish a curriculum that can be taught for nurse practitioners, PAs, doctors, prescribers, that would be you know, about uniform. And not maybe in a few months I might have a little more time. We can start working with you on issues, on things like that, where we would expect people to be able. It's almost like you have to pass a test on the benzos before you can prescribe them.
Right. Well, isn't there something like that with some of is it the opioids?
Well, with opioids now, of course, if you are prescribing most people working opiate dependency treatment are using Suboxone or buprenorphine,
right.
And with that, there's what is you have to take a course, you know, to become certified. And one of the things that's stressed in that course is not prescribing any benzodiazepines with the buprenorphine. Mm-hmm. When buprenorphine first came out in 2003, I had 6 patients in quick succession who all had problems breathing because they had been, before they came to the hospital, taking Klonopin or Xanax or something. They were taking benzos. Those drugs were still in their system when we prescribed the buprenorphine. So they all had the respiratory problems. We in fact had a patient collapse in our office. The patient was on buprenorphine and it was prescribed Ambien by his personal physician, which we weren't aware of, and he stopped breathing. And so we had to breathe for him, get him to the ICU. So now what the doctors are learning, they're learning about the dangers of combining benzos and buprenorphine. And there's a no-no. And then the state health regulatory boards come out with that. Well, we need the same emphasis, I guess, on the benzodiazepines that we do with the opiates.
Yeah. Well, and it's, been 60 years since they came out. Why do you think it's taking so long, even just to get, the latest FDA thing? Why is it so difficult to get change around this issue?
Where we have the users and the enablers, the doctors being the enablers, and I think it's multifactorial. Excuse me. And one is the lack of education we talked about the lack of education on the benzodiazepines, but also the lack of education in the treatment of anxiety and insomnia. I mean, there's not much doctors are prescribing medications for these conditions, anxiety, insomnia, without really having much knowledge about where's the insomnia coming from, where's the anxiety coming from. There's so much in that area we need to work on.
Well, and I guess when you say that, it makes me think, some of it, it kind of feels hopeless though, because the state of at least in the United States, our medical system, the way it's set up is, how can you really help somebody with anxiety in 10 minutes if that's what you have to spend?
You can refer to a counselor. Mm-hmm. Things are getting better, Nicole. Mm-hmm. You know why?
Why?
Because we're talking and we have this program. This is a start.
Yeah. Yeah. Well, and maybe, I don't want to say the coronavirus isn't that bad, because it is, but it's sort of opening doors, it looks like, towards, maybe insurance companies paying for more like telemedicine, where you can spend, more time maybe with your therapist and that kind of thing on Zoom calls, or just even being paid for more than would have been.
Yeah. Well, yeah. Well, one thing I'd say that Medicaid has been a big help. They're very good about paying for treatment for psychological conditions and chemical dependency.
Wow.
But that came for the Affordable Care Act.
Right.
Yeah.
Well, I'm aware of the time, and I know you've taken time out of your schedule today. You're working remotely, seeing your patients. So is there anything else you would like to add before we close?
Well, I'm just grateful that we had this program, Nicole, that we have the chance to chat like you and I did, and talk to some others and pass on this information. There's so much more to talk about, like what we didn't talk about, amnesia, for instance, that comes with the benzodiazepines, and how, and also those short acting drugs used for sleep, the Ambien, Sonata, Lunesta, and the dangers they pose,
Right.
On and on.
Yeah, exactly. We could talk for hours, I'm
You're
sure,
right.
about this. So maybe, you're not that far from me. I'll have to come down and visit sometime
Sure.
soon.
Good.
Maybe we can do another film screening down in Virginia Beach sometime for
Sure.
some doctors who need to see it or something like that.
Yeah. Mm-hmm.
Or maybe even at EVMS, where there's, the
Yeah.
students and that kind of thing. So, okay. So thank you everybody for tuning in today. We have many more interviews to come. If you haven't seen Medicating Normal yet, please check our website at medicatingnormal.com/watch to see a list of upcoming community screenings. We add more screenings there all the time and update that list often. Our next interview will be on October 22nd at 1 p.m. Eastern with Alto Strada. She is the founder of survivingantidepressants.org. If you have any suggestions for who you'd like us to have as a guest in the future, please give us ideas in the comment section below. We release new videos on our YouTube channel every Friday at noon Central US time, and we'll be having more live interviews here on Facebook Live every other week or so. We have many exciting people lined up, so stay tuned and tune in. You can see upcoming virtual screenings and the schedule for interviews by clicking on the events tab on our Facebook page, Medicating Normal. Again, thank you all so much for joining us today. Thank you, Dr. Ben, for spending an hour with me, and let's stay in touch, and I'll see you soon.
Thank you. Thank you.
All right.
Bye-bye.
Everybody.